everyone, and welcome to today's TEDMED live event. We're focusing on the obesity crisis. I'm Jessica Mark, and I'm going to be moderating today's discussion. It'll take about 45 minutes. This session is part of the Great Challenges program sponsored by the Robert Wood Johnson Foundation. The goal of the Great Challenges program is to look at 20 of the most complex problems in health and medicine. Now, these are issues that can't be solved with a magic bullet or a one-shot cure policy. Our mission today is not to solve these issues, but to share ideas from many disciplines to reach a better understanding of them than we had before. We'll be taking questions from viewers on Google Hangout and on Facebook on Twitter. That's Twitter at TEDMED. Just tag your questions with hashtag Great Challenges, and we'll try to get to them. As I mentioned, my name is Jessica Mark, and TEDMED has asked me to moderate today's event. I am the Director of Digital Content with Homefront Communications. I work on many health-related projects here, including the new public health blog from the Robert Johnson Foundation. But more importantly, we have a terrific team with us today of 5 experts who we call our challenge team, and they're going to lead the discussion on this topic. So I'm going to ask our team members to introduce themselves as we go through. And let's start with Dan Callahan.
I am President Emeritus of the Hastings Center, trained as a philosopher. The Hastings Center works in ethical problems of medicine and biology, and of course, the social problem of obesity is a central one these days.
Great. And James Zervios?
Yes, I'm James Zervios. I'm the Director of Communications for the Obesity Action Coalition. The OAC is a nonprofit organization whose main focus is to educate and advocate on behalf of all individuals affected by excess weight and obesity.
Wonderful. And Maya Rockymore, if you could introduce yourself, please.
Yeah, good afternoon. My name is Maya Rockymore. I'm President and CEO of Global Policy Solutions, a social change strategy firm based in Washington, D.C. And I'm also Director of Leadership for Healthy Communities, a national program of the Robert Wood Johnson Foundation focused on advancing policies that support healthy eating, active living, and childhood obesity prevention.
Wonderful. Thank you, Maya. And Rebecca Poole, can you introduce yourself as well?
Sure. Hi, I'm Rebecca Poole. I'm the Director of Research at the Rudd Center for Food Policy and Obesity at Yale University. Our organization is a nonprofit research and policy center focused on improving the world's diet and reducing the stigma associated with obesity.
Thank you. And Scott Kaan?
Hi, I'm Scott Kaan. I am a physician specializing in obesity. I work one-on-one with patients to help them manage their health and their weight and their lives. The other half of my career is as director of the Stop Obesity organization, which is a George Washington University-based policy and advocacy organization to extend the conversation on obesity and bring stakeholders to the table to help improve our approach to the epidemic.
Wonderful. Thank you all. So let me kick this off with a startling statistic. In 40 years, the U.S. population has gone from 40% overweight to 68% overweight. Half of American adults are dangerously obese, leading to many chronic conditions and deadly and expensive diseases. Now I'm going to direct questions to each of our experts here as we get started. Thinking first, what is the top, maybe unexpected contributing factor for the great challenge, the obesity crisis? And is there something that maybe conventional thinking overlooks? I'd like to direct that to you, Dan. Let us know what you think about that.
Is the question what we may be overlooking?
Yes, what's something that's
well, I have a number of things. That it's very hard to find something that's being overlooked in an area that's had an enormous amount of research. Rebecca and others at the Yale Center have done terrific things. I'm mainly fascinated. I noticed looking around, it doesn't look there's like a single obese person or overweight person on this program. What is there about us and the way we were raised that led us not to be overweight? Secondly, I'm interested in I know a lot of educational activities over the years have not been very successful, but I'm fascinated by the people who do take the initiative to decide to do something about themselves. And how did that come about? Did they not like the way they looked? Did they feel socially stigmatized and had to change? So I'm really interested in the intersection between large social pressures for being overweight and the sort of link between that and individual behavior. What motivates people to either let themselves be overweight or says, I don't want to be that way.
Great, thank you for that answer. Maya, what are your thoughts on this?
I think that obesity is a complex disease that we have to be careful about attributing any one factor to. But if I were to name a factor in response to your question, I would say it's the consumption of large amounts of sugar combined with high carb diets that are frankly our bodies aren't suited for, coupled with the lack of exercise that many people have, basically we've translated or transferred into a sedentary lifestyle, many of us. So the foods that we eat are high in sugar and high in carbohydrates. And I'm talking about highly refined carbohydrates, not naturally occurring carbohydrates. And our bodies are unable to process these things in a way that allows us to have a normal weight. So the diet is one that I would focus on.
Thank you. And Scott, do you have any thoughts on what Maya and Paul have shared? Dan?
Well, if I understand this question correctly, you were asking what is perhaps the top unexpected contributing factor to the obesity epidemic. From a clinical perspective, one of the things that interests me very much is and surprises me very much is that gut bacteria seem to be correlated to obesity in many individuals, and that's something that you can explain away in some ways physiologically, but we really don't know whether it is or not. So that's something that I think is very interesting. What I think is perhaps a big picture issue here that is important to realize is that if you asked this question perhaps a decade ago, I think many people would say that the top unexpected contributing factor is that the environment is a strong factor and contributor to the obesity epidemic. Now, because of a lot of the work that many of the people on this panel and outside throughout the society that have been working on this area have done, that is no longer unexpected or surprising for most people that are looking at this. We now know, and I think it's been quite well popularized, that the individual plays a part, but the individual lives in a much broader society and community and set of circumstances, and it's these things that we live in, our society, our communities, etc., that are very important factors in terms of what we do, in terms of a number of different health behaviors, but certainly in terms of body weight regulation and ultimately obesity risk.
Great. We've had a lot of great answers there. We've actually gotten a question in from Facebook I'd like to address. This is from Jill Boso. And Rebecca, I'd love to get your thoughts on this. How can healthcare better engage and collaborate with other public and private entities to propel more innovative approaches for responding to and preventing obesity?
Well, I think that we can do much more to encourage healthcare providers to really be engaging in policy level discussions that can actually create systemic changes in our environment that would help address obesity. Health professionals, health providers, they have a very powerful voice, and that voice extends well outside of their medical offices, but we're not engaging these voices as much as we should be. And I think that many health threats of our time have really required collective action from the healthcare community. We can look at examples such as the control of infectious diseases. And we need to really look at the important role and voice that healthcare professionals have in these historical examples and apply that same thinking here with obesity. We need providers and professionals to be weighing in on policy decisions and discussions related to things like nutritional standards in schools, taxes on sugar-sweetened beverages, regulation of food ingredients. So I think they need to have a stronger seat at the table.
And I would actually like to add to that, that I think that while the Affordable Care Act has done a lot to focus on prevention, we actually need to go the next step and actually focus on wellness. And when I speak about wellness, I talk about primary prevention. Many private companies are actually doing a lot of interventions with their employees that focus on, providing them with nutrition education, providing them with incentives to join gyms, for example, providing them with diabetes maintenance and prevention interventions. And so there are a number of primary prevention tools that allow people to get the supports that they need to change their lifestyles. But how do we bring those kinds of interventions to a larger population? And I actually think that the next step for healthcare reform in this country is to actually push down to the level of wellness and primary prevention, and maybe looking at the Affordable Care Act or other mechanisms at the policy level, as Rebecca has just mentioned, to actually insert supports that allow a broader array of people to get access and incentives to access these kinds of benefits.
This is James. I'd like to add to Maya's point as well. And one thing that the OAC stays aware of with the incentives is that we often see the incentives more or less structured as penalties, and that's something that the OAC is always very careful of, is that when these are in place, they should not be penalties for individuals who are trying to improve their health, but they should be real incentives for them.
Interesting. Thank you all for that. So we've heard a lot about the different roles that different players can have in this problem, and clearly one of them is physicians and healthcare, and perhaps the Affordable Care Act can propel us forward in that respect. We have a related question from another participant on Facebook, Monica Elliman, and that's, why aren't our national clinical practice guidelines as effective as some international guidelines, particularly when we're talking about pediatric obesity prevention? And how can organizations determine which guidelines they would like to implement in practice? Dan, do you have any thoughts on that?
Well, my main area is healthcare and health policy very generally, and particularly in areas like end-of-life care, critical care. There are guidelines galore. An enormously difficult problem is not to formulate the guidelines, but to get physicians to take them seriously and to follow them. In the area of end-of-life care, physicians just don't want to talk about people dying. It doesn't matter. The guidelines are lovely, what you should say when you talk with them, but it doesn't tell you how to get up the nerve to talk with them. So you have a fundamental gap there between the guidelines and behavior. So to me, the question is, how do you educate healthcare workers, physicians, and the like to take these issues seriously, and then to act on what they know? And I suspect in many cases, for physicians, say in the office, they find it awkward to sort of start commenting on somebody, the way you look sort of overweight, and I suspect it's one of those things that leaves many physicians rather uneasy, and you're not supposed to invade somebody's life like that.
Let me add to that I started just 2 years ago the first class on obesity at George Washington University for medical students. As far as I know, there's only 3 or 4 of these classes throughout the country. In many cases, it's hard to even get a single lecture within 4 years of physician training in medical school. Hard to get even a single lecture into the curriculum. In the course that we did, the students, they loved the class. They really wanted to learn more about obesity and how they can help their patients who have obesity. It was really a great opportunity that isn't available to most medical students. So I think that's part of the answer to this question, is that it has to start at the very early parts of training for medical students and other young healthcare providers. I'll also say that the premise of the question suggests that we're doing a poorer job in terms of our clinical guidelines or interactions with patients in the U.S. versus outside the U.S. I'm not so sure that's the case. I think internationally there aren't many good examples, if any, of countries and healthcare systems that are doing a great job in helping patients with obesity. Our rates are a little bit further along than some of the other countries because we've had this Western type of society for a longer period of time, so people have had a more opportunity to develop obesity. But I think that this is an international problem and not just one, certainly for America.
Could I ask Dr. Kaan a question? I'm really curious whether underlying the problem of the student interest in obesity, but you have to get a more fundamental issue almost with medical students. How do you get them interested in actually talking with people about their health as distinguished from simply diagnosing them and giving them a pill or say you better see a specialist? It seems to me that that's sort of the key. A doctor, a physician has to be, or a nurse has to be observant and then has to be willing to talk. And I think many are not trained to talk very much.
And this is Rebecca. I'd like just to add to that. We've done, considerable research looking at interactions between patients and providers having these kinds of discussions about weight and how easily these conversations can feel stigmatizing to patients. And what happens is patients don't want to return back for treatment and healthcare services. So I absolutely agree that there needs to be considerably more training for healthcare providers on how to have conversations about weight that can be positive and productive conversations without stigmatizing their patients. I think that's really absent right now. The other thing I think is that a lot of times providers certainly do want to help, but they don't know what to recommend. And that is also in part because of the lack of training on nutrition and obesity. So, there's some real gaps here in medical training that need to be addressed.
I certainly agree with that. In my experience, and of course it's limited to the students that I've worked with, but in my experience, young medical students absolutely crave more training and information on various health behavior change strategies and preventive medicine strategies. They want to talk to their patients. They want to help their patients. The medical students that I've worked with have a sensitivity to patients that I think was really quite wonderful as I got to know them. Some of what you see, Dan, I think in the healthcare system is that over time, as physicians are ingrained in the healthcare system and having to work within a system where they have 5, 8, 10 minutes to interact with a patient and little training in how to interact with patients on behavior change areas, I think it gets it feels quite futile and gets very frustrating, and that may be something that contributes ultimately to physicians not doing so well with patients with obesity or other chronic diseases.
And of course, the problem in a funny way, the bottom line always is you're going to...
I'm sorry, I just want to jump in because we have a new participant who's joined us, and I want to make sure we have the chance for everyone to hear a little bit about his background. John Auerbach, can you hear us?
I can indeed.
Great. Can you tell us a little bit about yourself?
Yes, but first let me apologize for joining late and interrupting this discussion. I am, as of a month ago, a professor of practice and the director of the Institute on Urban Health Research at Northeastern University in Boston. Prior to joining Northeastern, I was the Commissioner of Public Health for the state of Massachusetts for 5.5 years, and prior to that, for a decade, I was the City of Boston's Health Commissioner. So on the issue of addressing obesity, for me, I look at that now at a university setting, but for the last 15 years prior to that, as a public health official that was trying to think about what are the policy implications and how can we work at a governmental level to change the conditions in people's lives so that we're less likely to be seeing these trends continue. So again, apologize for entering late, and thank you for letting me join.
Maybe a new question here around, maybe you can kick it off. We've heard a lot about the role of healthcare and what physicians can do, and maybe better training in medical. How can public health and and others and care to try to address this problem?
Was that addressed to me in particular?
Yes.
Well, thanks. I think that from a public health less from the perspective of working on a one-to-one client or patient level, but more about creating conditions in people's neighborhoods, in the schools, in their workplaces that make the healthier behavior the more likely behavior. And that means being very creative, thinking about everything from laws, regulations, community involvement, broad coalitions, and increasingly in public health it means that we have to operate outside of our traditional comfort zone of working only with other public health people or only with people in the healthcare field, and we have to become directly involved and respectfully involved with people that are overseeing our schools, the education departments. We have to be involved with disciplines as diverse as the people who are doing transportation system planning, city and town planning. We have to think about zoning. When we think about obesity, we have to think about all the different ways that we can have a positive influence on the conditions of people's lives so that it's more likely that as they're getting counseled and they're getting information, it's less work to try to address an issue as significant as obesity.
Great, thank you. Does someone else on the panel want to address that question as well? Maybe.
I agree with him that public health is broader than just the discipline of public health. It's actually embedded in our public policy. So state and local elected and appointed officials, federal too, are critical public health advocates who need to understand that the decisions that they make on behalf of their communities or their states or the nation can have an adverse impact on people's health, but it can also have a positive impact on the obesity epidemic if they're focused actually on looking at how all of these factors intersect. So in addition to schools, we know that in the schools it's everything from the vending machines to what's in the lunch line to whether or not kids are getting physical activity. In neighborhoods, it's the same thing. Do you actually have green space where people can get physical activity safely? Do you have parking, biking lanes and walking trails so that people can get out and engage in physical activity? Are your communities designed in a way that enable people to easily get to their destination using active transport where they can lose the reliance on automobiles and increase the use of either biking or walking to their destinations? This is a multidisciplinary approach that takes committed and active engagement across sectors, and certainly public-private partnerships can help to advance this effort as well. And I would also, I'd also like to add we cannot forget communications and marketing because many people are seeing unhealthy foods and beverages marketed to them in multiple places. And so, being able to address that as well is an important public health goal.
Could I ask Maya a question? Namely,
sure.
This really implies that most of the important work will be at the very, very local level where people can exactly observe everything that's going on and decide what to change. If it's done too broadly and nationally, it seems utterly overwhelming. But if you can get a town, I live in a town of 8,000 people, if you can get that town mobilized and the public health people will say, now look at this, look at that, and you could probably do something. But if it's the whole state of New York, it gets a little trickier, much less the entire U.S. So.
Well, I would actually argue that they operate as embedded eggs, if you will. So at the local level, you absolutely can see directly what kinds of systemic changes need to be made to your community or to your schools. But at the state and federal level, you can provide supports, funding, and incentives that can help the local level execute those strategies. And so we can't write off these state legislators or the federal
I think that's a
policymakers.
good point. That's where the money comes from to do some of this stuff too.
I would agree with that too. I've had experience in dealing with the quality of the food that's served in schools. And when I was a city health commissioner, we were working school by school, neighborhood by neighborhood. And the truth is, making those changes at that level was resource intensive, and ultimately we couldn't scale up those changes to have any measurable impact. It just it just meant we had to get to know the principal and work on the policy changes. Once we knew what worked and what the standards should be for schools to have healthy environments, we wanted to move to the city level for policies as fast as possible, and then to the state level as fast as possible. So I really agree that we need to think of working on all the different levels simultaneously, although very often it is the local level where the innovation begins and the evidence is gained that allows us to think more broadly about then how to expand the policies.
Great. Thank you all. I want to touch on one thing that Maya said a little bit ago, and that was the potential for public-private partnerships and how that can provide a new opportunity. And there's actually a related question by one of our viewers on Google+, Lisa Fields, asking about if anyone on the panel knows anything about the Safeway Healthy Measures program that was addressed in the documentary film Escape Fire. And even if you haven't, I'd like to broaden that question a little bit to ask, in a time of scarce resources when clearly we need to draw on everything that we can, what is the role as well for both employers and businesses to really take some ownership and leadership in this area? And James, I would love to hear from you on that.
Well, I think it's an interesting question, and in kind of tying back into the previous discussion just a bit, that while a lot of these policies are wonderful, it tends, when you get down to the local level, you find sometimes things still operate in a vacuum. I know for a fact a lot of schools, they still do cookie drives, and whoever sells the most chocolate, they win a prize and this and that. So in order to impact change, I really do think you have to start with the individual. And businesses and employers, they can all be a part of that. So I think sometimes when you have these sweeping measures, it's often difficult to implement them at the local level to make sure that they are taking an effect and that they are making a difference.
This is Rebecca, and I think that, in terms of the question about what can employers be doing, what should employers be doing, I mean, there are major changes in workplace structure and culture that could significantly help with prevention of obesity. The workplace provides lots of opportunities to promote weight-related health, but oftentimes it does the opposite. We see vending machines installed, we see little opportunities for physical activity, we see lack of incentive for healthy behavior. So in terms of what workplaces can do, I mean, they can offer tremendous educational resources and support. They can provide a healthy environment. I think if employers are going to expect their employees to engage in health behaviors, that they need to provide an environment where that becomes feasible in the workplace. And to be focusing on overall wellness for their employees, and really rewarding employees for taking steps to improve their health measures, even if that means getting a nutrition screen or getting their blood pressure checked or getting these different indices of health measured. There are so many things that employers can be doing to improve this.
I would like to add to that we've seen a number of public-private partnerships taking place across the country, and it's really been encouraging. At the local level, with the issue of food deserts, these are neighborhoods that don't have access to fresh fruits and vegetables. They don't have full-service supermarkets. We've seen cities, and certainly with support from the federal government, actively reaching out to supermarket vendors to ask them to locate in their communities. And we're seeing this start to take place where these food deserts are being actually populated by full-service supermarkets. So the Safeway example that you mentioned is one where the Safeway has decided that they're going to do things to actually educate their consumers about healthy options. We've seen it also in terms at the local level in terms of restaurant partnerships, where the public sector has partnered with private restaurants to get them to offer healthier menu options. We've even seen city mayors partner with restaurant chains to actually acknowledge and reward them when they actually introduce healthier measures on their menus. So there are a lot, and this is just the tip of the iceberg, you know, from joint use agreements, you name it. We've seen partnerships working and to address this issue.
Great, thank you. I want to jump in and change directions a little bit. We have a really interesting question from TEDMED.com from Roger Holtzberg. And this is about technology. He says, with over 100 million Xbox and Wii boxes in American households and the rising focus on active and fitness games, what do you think these technologies can do to help with childhood obesity, and what would your advice be to the companies who are making these games? Scott, do you have any thoughts on that?
Well, I don't have a lot of experience in this area. There was a study out recently that showed that kids that play these extra games that they don't have as much impact as we would have liked to have seen, as we thought they might, as much impact as we thought they might have had in terms of being active. So, you know, it's hard to say how effective these things will be, but at the same time, you know, little bits of being active here and there, little bits of healthy decisions on the other end in terms of food intake are extremely important. And when we can bundle these things together, then there's synergistic effects in terms of ultimately our health outcomes. So I think it's important not to poo-poo any given individual potentially beneficial area, and certainly theoretically at least, technological advances should be more and more important going forward as more options are available.
I would actually add to that. I know at Northeastern University now there's research with some of the developing apps that can actually send reminders to children or to adolescents and adults about healthy foods to eat. They can be interactive in terms of putting in information and then receiving notification about calories. So I think that there is something to it, and I think we're in the research stage of understanding how to take advantage of those technological tools and the use of the internet as one more piece of an overall approach that may help.
I'd like to add to that as well. I think you really have to look at it as maybe an entry point. If you have a child that likes playing tennis on, you know, the Wii or something like that, use that as an entry point to then say, okay, you played it on a video game, why don't we go try it, you know, go to the Y or something, and just to get them interested in physical activity at least.
And I'd just like to add to say that there's been an explosion of these exercise videos, whether that be yoga, whether that be, you know, you name it, aerobics, whether that be weights. You have apps on your phone, you have videos that people, or CDs that people are ordering for their homes that are really working, and people are using them and following them, and even apps that can actually be integrated into your daily lives. You know, apps that can actually track the steps that you take and you know, review the nutrition profile of the foods that you eat as you're eating them. And so I think that technology can be a great booster and incentive to promote healthier behaviors.
Great. I want to address a question now from Facebook. This is from Song Young Her, and the question is, it's been frequently debated whether it's the responsibility of society or the individual to address obesity. I think that's come up a couple times here. What attitude do you think is more effective to have for health professionals in the field? Is it a social or an individual focus?
This is Rebecca. I'd like to talk about that. I think that, you know, if we only focus on personal choice and responsibility, then we're really limiting ourselves to an approach that focuses on trying to change people's behavior one person at a time, and major societal contributors of obesity end up getting ignored. But if we recognize the importance of making positive changes to the environment in which we live, then policies can help create a society where making healthy choices and engaging in healthy behaviors becomes easier. You know, for much of the last 50 years, many of the approaches to diet and obesity have primarily focused on the individual. Until recently, the focus has been to primarily educate people or persuade them to change their lifestyle behaviors. And this overemphasis on personal responsibility has really prevented needed policy changes from being implemented that could actually help facilitate personally responsible behavior. So I think the reality is that both collective, social, and individual responses are important, and the challenge is trying to figure out how to combine personal and collective approaches in a way that really improves public health.
Well, my impression of the public health community is that it's very nervous in general in talking about individuals. It likes to look at a kind of system level. It seems to me the fascinating question is, so, okay, you change the culture in many ways and you provide many incentives to do the right thing. At some point, somebody's got to decide, well, I'm going to look at the calorie chart. How do you make, that's the individual there's individual decision making at some level, no matter what you do socially, that somebody's got to take it seriously. Somebody's got to decide, I want to talk to my doctor about my weight.
Go ahead.
Oh, I was going to say, I certainly feel like there is an important role for personal responsibility, but I think if we look at what's happened with the obesity epidemic, it really is something that only began to be a serious health problem in the 1970s, and from that, and it was really related to policy changes and in ways that particularly people who were lower income had very little control over. It's only in the last 20, 30 years that we've gone from a situation where the poorest people were the thinnest people because they didn't have enough money for food, to the exact opposite now, where we have much more overweight and obesity among the lowest income residents in the country, and that's because their choices are limited, and if the policies are ones that encourage or only allow an option that's an unhealthy option, they really don't have individual choice because their resources may be limited. So I think that the combination of personal responsibility and policy is a proper one, particularly for people with limited resources.
Well, it seems to me that I think that's all absolutely right. The difficulty is when what you need are such massive social changes that are going to take an awfully long time to bring about. You can point, well, we have this great successful test program in the high school in some place in Kansas, but how do you move to the larger level and really change the behavior of society? That's where I happen to work in global warming, and it's a similar situation. Everybody says, well, we basically got to change everything about the way we live our lives, the way industry operates, et cetera, and it almost becomes utterly daunting at that level.
It certainly does seem daunting to make change on such a large level, but it's something that is possible, and it's something that we have a number of analogies from other areas of public health that have been very successful in this area. One, for example, is the tobacco smoking epidemic. Now, there's limitations certainly in comparing the tobacco epidemic to the obesity epidemic, but nonetheless, there are a number of very important parallels. The approach to tobacco started in the late 1940s when we began to have very solid evidence that tobacco was extremely unhealthy for us. We started teaching people that it's important not to smoke, to quit smoking. There was a Surgeon General report by Luther Terry in the early 1960s. Throughout the 50s, 60s, 70s, we were teaching people how important it was to change their behavior, and it made very little difference on its own at all. That, though, combined with a number of structural and environmental and policy changes that began to be initiated in the 1970s and 80s, some changes in taxation and the economics of smoking, changes in marketing, acceptability, changes in access, and so forth, combined with that education made quite a difference. So rates of tobacco use started going down quite quickly by the 1980s and into the 1990s. And then you combine that again with some useful individual interventions that were then available in the 1990s, like nicotine replacement therapy. There were some medications that were available, tobacco quit lines, improvements in counseling. And so again, you know, this is what we've been talking about this whole 40 minutes now. You take a top-down approach from the environment and policies and such with a bottom-up approach from the individual level, and you combine that and we can make quite a lot of progress. And it's not going to happen overnight, but this epidemic didn't occur overnight. We're already making some progress, and we need to keep forging along in that way.
As a big-time smoker some years ago, though, I was under enormous social pressure from friends and family, and that made as much a difference. I had enough money that I didn't care what the taxes were, but boy, everybody leaned on me and basically said, you know, you're just not only bad for you, but you're hurting us by smoking around us. And I think that was very effective. Now, many people in the obesity world get very nervous about using the success with tobacco as a kind of model, because we in fact stigmatize smokers, I think, very significantly.
Well, I think there are some important distinctions.
I want to make sure we get to a few more of the questions that we've been getting in here. There is another question from Jay Chang on Google+, and I think there's some interesting parallels again with the tobacco parallel, and this is that in a society where fast food, and I would say probably other foods as well, is quick and most importantly cheap, what have we done to educate and encourage adults to cook healthy foods at home? And I would think a little bit about sort of what are we up against? You know, it's a hard sell in a time where healthy foods in some places are hard to afford, whereas the things that are cheap and quick are more accessible. So what do you think we can do about that?
Well, I'll speak to that.
Sure.
You know, I actually think that quite a lot of education has been done, but it hasn't been as effective as we want it to be. And that's not because people don't understand the messages, but because the feasibility of achieving these goals in our current environment is limited. You know, we can spend tremendous effort and resources on educational efforts, but if we don't change the environment again in a way that actually supports those healthy behaviors, then the efforts won't be as successful as we need them to be. So again, making policy changes that directly affect the food environment and create healthier defaults that support families in our society to become healthier rather than having all of these unhealthy defaults, that will get us more mileage. So I think that's really, again, the theme that keeps coming up in these responses.
Great. And Scott?
I would agree completely with Rebecca. I don't think that we have done nearly enough to help people both understand the importance of, but have realistic skills and opportunities to eat more at home, cook more at home. You know, in general in our society, the unhealthiest and most high-calorie foods are the most available foods. They're the most accessible foods. They're the cheapest foods per calorie. They're the most heavily marketed foods, and in many ways, they're sort of the most fun foods. You know, that's how they're marketed with fun characters and cartoons and so forth. And so we need to tip that, of course, on its head. There needs to be improved training for people to cook healthfully at home. There needs to be changes in other defaults that allow people realistically to have the time and ability to spend the time and effort to do that. I mean, fast food is not only so frequently used in our culture because it tastes good and because it's cheap, but also also, quite frankly, because it is fast, and we are progressively more and more all running around and working very hard, and that's a wonderful thing in many ways, but it leaves very little time for us to take care of ourselves, take care of our families, and without that, it's very hard to expect people to invest the time, let alone the money and such, to be able to do healthy things for themselves and those around them.
I think this is one of those areas where there really isn't a single fix. It really takes looking at lots of different approaches. There are many, I'd say throughout the country now, there are many efforts to bring farmers markets into lower income communities and make fresh fruits and vegetables more accessible. There's certainly efforts that have been undertaken at community health centers and other locations where there have been classes in cooking healthier foods, and there have been efforts that respect the cultural and traditional ways that people put food on their table and try and offer people suggestions about how to make a healthy substitution, but one that still retains the food that is part of that family's history and culture. So I think that those multiple changes all are needed. Zoning incentives to bring more supermarkets into all neighborhoods, I think, are part of the picture too. But just unfortunately, there isn't a single approach. I think it's going to take lots of different strategies and creativities and working at different levels, as we've been saying.
Thank you, John. I want to get to one last question here. This will be our last question today. This is from Lindsay Mazur via Twitter. Why is the research showing it that obesity might not be a crisis publicized? And she cites a study that says that obesity rates have started leveling off. Maya, do you have any thoughts about that? Oh, Maya, I think you might be on mute if you want to just...
Thank you, so sorry. What we're starting to see is obesity rates level off, particularly in those areas that have prioritized policy change early. So, for example, the New York City area, Los Angeles County. We're seeing cities that have prioritized policy change actually start to see, Philadelphia, actually start to see the rates level off, and that's a great thing. That suggests to us that the public health efforts that are focused on policy change and public education can be helpful to change behaviors in a way that actually will see our obesity rates not only level off, but in the future, hopefully reverse.
That said, obesity rates are leveling off in some categories of our society at extraordinarily high levels. So unfortunately, it's not all good news there.
That's right. And that's right. In fact, I'm sorry. In fact, we're seeing, unfortunately, people of color are not experiencing the same leveling off rates, which suggests that we need to have some targeted interventions that actually specifically address and support these populations as they seek to reverse their obesity weight challenges.
Thank you all so much. I just want to mention that any questions that we did not get to, we will address on the TEDMED blog, and we'll post them there, so stay tuned for more. I want to say a big thank you to all the TEDMED panelists here, the team members who provided their time and their thoughts, to everyone in the community here who watched and sent questions. We really appreciate it. We've heard some really interesting things today. Remember, we're going to keep the dialogue going at TEDMED.com on the Great Challenges page for the obesity crisis. And the same goes for TEDMED's Facebook page, so keep posting your comments and questions. And finally, we just want to say a thank you again to the Robert Wood Johnson Foundation, sponsor of the Great Challenges program. Thanks again, everyone.
Thank you. Thanks.
Thank you. Thanks very much.
Bye.